Thank you for your presentation. Thank you, Andrea, for this kind invitation to this meeting. We already discussed the role of surgery and, in part, the role of medical treatment in endometriosis. But which is our aim when we have a patient with endometriosis? Is it to remove the nodule or to consider her symptoms, her fertility, her quality of life, and maybe her comorbidities? Questo gira. You can see listed here all the most common therapies that have been used to treat endometriosis. Obviously, contraceptive, oral contraceptive, vaginal ring, transdermal patch, and progestogens are the most commonly used therapies. And they should be considered the first-line treatment for endometriosis. In this review performed by Professor Vercellini, you can see that several studies have been published demonstrating that oral contraceptive pill, noretisterone acetate, medroxyprogesterone acetate, they all cause a significant improvement in pain symptoms of women with endometriosis. In particular, the patient included in this study had deep endometriotic nodules, therefore they were highly symptomatic on VAS scale. However, they still had improvement of symptoms without undergoing surgery. And the evidence is that several symptoms improve. There is improvement in dysmenorrhea, chronic pelvic pain, dyspareunia, and there are also some improvement in intestinal symptoms. We performed a study comparing a very simple therapy, which is primolutinol in Italy, noretisterone acetate, to a combination of noretisterone acetate and letrozole in a patient with endometriosis. And in this study, we quite recently demonstrated that this treatment allows patients to avoid surgery and cause an improvement in the intensity of pain symptoms, but also in improvement in some intestinal symptoms, such as those that you can see listed here, particularly diarrhea, abdominal bloating, mucus in the feces. The most important thing is that hormonal therapies does not resolve the problem, obviously, and therefore, when the treatment is interrupted, the recurrence of symptoms is very quick. In this slide, you can see patients treated with noretisterone acetate on the left and those treated on the modern letrozole and noretisterone acetate on the right. In particular, for each type of symptom, you can see the baseline intensity of symptom and then the intensity of the symptoms 3 months, 6 months, and 12 months after discontinuation of therapy. And you can easily see that when the treatment is interrupted, the recurrence of symptoms is very quick. The symptoms goes back to baseline. Independently from the type of treatment that you use, even if you use aromatase inhibitors, which were supposed to be the most innovative treatment of endometriosis, when you stop the treatment goes back to the original intensity. Given this perspective, it is possible that the easier things are the best. And this Cochrane review shows the efficacy of progestins in the treatment of endometriosis. We recently were asked to perform a systematic review on the medical treatment of endometriosis by the clinical evidence of the British Medical Journal. Obviously, there were several questions that we had to answer in this systematic review. However, the main points that came out from this review were that hormonal treatment significantly reduced the severity of pain symptoms caused by endometriosis. And this happens either after surgery or as an alternative to surgical excision of endometriosis. Obviously, the current available medical treatment do not improve fertility. In contrast, they are contraceptive, and this is an important problem for women wishing to conceive. First-line treatment is oral contraceptive, progestin, and the Mirena, the levonorgestrel-releasing intrauterine device. This treatment causes significant improvement in pain symptoms and ameliorate quality of life. Nowadays, we should avoid gonadotropin-releasing hormone analogs and danazol because they cause, obviously they improve symptoms, but they cause several adverse effects that are well known, and they cannot be easily tolerated by young women with may desire to have a normal life. Aromatase inhibitor should just be considered an experimental therapy, and there is no evidence that they should be currently used for the treatment of endometriosis. They may have a role in those patients who had already multiple surgical procedures and they still complain pain, but it's quite difficult to really understand the role and the potential of these drugs. The most important thing is that hormonal therapy can change the volume of the nodules. It is well known, several studies over the last 10 years demonstrated that rectovaginal nodules decrease in size during treatment with oral contraceptive pill or progestogen. Recently, we showed that even when the nodule infiltrates the bowel, the rectum, there is a rectovaginal nodule infiltrating the rectum. If we administer some treatment, some hormonal treatment, oral contraceptive pill, GnRH analog, progestin, or what else, we will see a decrease in the volume of the nodule. However, we must consider that we do not really treat the problem. In fact, the disease might progress in some patients. And this is very relevant. In this figure, you can see a patient which had a quite small sigmoid nodule, which had an increase in size after 2 years of hormonal therapy. Limited data are available on the progression of endometriosis during hormonal therapies. This is a study that we recently presented. The main point is that even if the patient is asymptomatic, which can occur quite frequently, the nodule may have an increase in size. In particular, in about 100 patients which were treated with norethistron acetate for 5 years, we noticed an increase in the size of the nodules in about 11% of the patient. And the most significant thing is that several patients which had increase in the size of the nodule did not have big symptoms, did not complain big symptoms, so they were happy with their therapies. And it may also happen that if you don't perform a monitoring, a follow-up of the patient, the disease goes on, arriving to have intestinal lesion, lesion on the diaphragm, lesion on the ovaries, and even on the umbilicus. Obviously, all the surgeons, all the people who perform endometriosis surgeries know that when they do surgery, very often the patient has used some type of hormonal therapy for years, maybe because she wanted an improvement in her pain symptoms, or she had simply the desire to have contraception. So it is clear that at least in some patients, the use of hormonal therapies does not prevent the progression of the disease. However, surgery has some risk, and therefore not all surgeons, not all gynecologists may want to perform this type of procedure. However, the procedures are effective. Several studies not randomized demonstrated the improvement of all pain symptoms after surgery, even with long-term follow-up. There is also one randomized placebo-controlled trial which demonstrated that performing diagnostic laparoscopy or excision of the lesion cause different effect on the intensity of pain symptom, but also on quality of life. And more importantly, when after 6 months the patient had second surgery, the patient who had just a diagnostic laparoscopy had second surgery, they had an improvement of the symptoms. Therefore, definitely there is a role of surgery in improving the intensity of endometriosis-related pain symptoms. However, there is only this study, which was the study that I just showed, showing that the effectiveness of surgery, of surgical excision of endometriotic lesion in improving pain symptoms. I am saying surgical excision because obviously when we discuss surgery, it's very difficult to compare one surgical procedure to the other. It might be that some surgeon just does a laparoscopy and maybe a cauterization of the lesion without removing the deep nodules, and this obviously cannot be considered surgery for endometriosis. However, with the limitation, depending on the surgeon and on the type of procedure that are performed, the risk of having a second surgery is real. In this study, you can see in the black line that in long-term follow-up, 8 years, 7 years, most of the patients who had surgery may undergo a second operation unless they undergo ovariectomy and hysterectomy. Therefore, women with endometriosis are at high risk of having multiple surgical procedures. When we treat a patient with endometriosis, we also have to consider that this patient may suffer other disease or they may have other problem. Therefore, in the perspective of giving a medical therapy, independently from the fact of performing surgery at a certain point of life, we may have to prescribe a therapy which should be done for years, not to treat the disease for 6 months, but for years until they will want a pregnancy. In this perspective, we must consider what is really tolerated. And we recently analyzed which are the effect of different type of hormonal therapies on migraine, which is quite common in women with endometriosis. This is just one study. There is not big literature in considering the potential adverse effect of different therapies on migraine or on other comorbidities of patients with endometriosis. But this aspect should be considered because if the idea is to administer chronic therapy, obviously the patient must tolerate the chronic therapy. In this perspective, in particular, we considered women with migraine but without aura, which obviously is a contraindication to the use of oral contraceptive pill. And we clearly showed that the administration of the desogestrel-only contraceptive pill is superior to the estroprogestin combination in reducing the severity of migraine attacks and the number of migraine attacks with a similar improvement of pain symptoms. Therefore, we should think for the future that we must not only consider the improvement of pain, the improvement in quality of life, but also the improvement of the comorbidities that this patient might have. In conclusion, hormonal therapies should be offered to women with endometriosis. But these patients should be informed that the disease might progress during treatment. And if we decide to avoid surgery and prescribe hormonal therapy, it is required that we carefully monitor the patient in order to see if there is a problem with the ureters, if there is bowel stenosis or other problems. Progestin and oral contraceptive pill should be considered the first-line treatment because they are cheap and they are efficacious in reducing the intensity of pain symptoms. The main problem is that all the available therapy are contraceptive, and therefore we do not have any medical treatment for symptomatic patients with endometriosis patients which have pain and desire children. Surgery must be performed in some cases, obviously in patients who still have pain despite the use of hormonal therapy, because this happens. In patients which have adverse effect during the use of hormonal therapies, when there is a problem with the ureter or a bowel stenosis in general, it is suggested that it is required to perform surgery when the bowel lumen is less than 30–40%. And also we have to perform surgery when there are contraindications to the use of hormonal therapies, for example, patients with other diseases, systemic erythematosus, lupus, and so on. When it is desired, probably trying to conceive and childbirth may improve the quality of life of the patient and may help in tolerating herpes symptoms. Thank you for your attention.